This Lunch and Learn is brought to you by The Candy Factory, a co-working and social club here in Lancaster, Pennsylvania. Visit coworkinglanc.com for membership details and to schedule a tour.
So today I wanted to talk to you guys about healthcare. I know we all get really excited about that. And I just want to set kind of a stage of what we're talking about. If people can silence their phones before we get started with this, that would be wonderful. So today we're going to talk about healthcare, not specifically insurance related, but more so the fact that we all have our own unique scenarios when it comes to paying claims, handling costs, and a lot of that comes down to the fact that healthcare really drives 20% of our GDP in the United States. So that was kind of my first statistic. I stole my own thunder. $3.8 trillion was spent in 2019 regarding healthcare. So today we're not talking necessarily on the clinician side and treatment and diagnosis and medication, but more so on transparency and talking about what you can do as a consumer, what has originally been the framework for how we pay for healthcare, how we're dealing with it now, and what the next steps are, barring whether you get it through an employer or individually. So I have here healthcare accounted for 17.7% of GDP, which is a huge statistic. We're going to talk through our vantage point. I always think it's important to know the lens that the person you're getting information from, their lens is on the topic. And then we're going to walk through a history lesson. I'll be as quick as I can through that because I know some of us aren't history buffs. I'll walk through what we've done since the turn of the 20th century and also what's happening over at least the next 9 years. It's hard to say after that, but what the intent is, at least for healthcare. So I'm sure some of you have heard this story before. This is my little guy who's not so little anymore, Kieran. My son was born on New Year's Day about 8 years ago. And it was our first child. This is obviously before and after the birth, but it's something that's stuck very close to my background, going from talking about financial planning as a financial planner to talking about healthcare in all of its extents because of my personal experience, where he was born on New Year's Day and we had to walk away with double deductibles, double co-insurance, double co-pays, because technically his mom was admitted in a different year than he was. So, I know. So that drove kind of a shift for me to try and help other people. Now, as a financial planner, it's all about due diligence and understanding the market and providing advice. So as a type A person, I asked every single question I could when he was still inside of his mother. Not to know that had I waited a day, I would have cut my medical costs in half, which was not the responsibility of a nurse or a doctor or the register when we got admitted to the hospital. It was just an unfortunate event that happened within the system. Since then, we built a practice, PA Health Advocates. It's a brick and mortar out of the Candy Factory. And my family's grown a little bit. So we've gone from me and Kieran to Daxton, my wife Abby, and Erica, who's sitting in the back, and Aislinn, who couldn't be here today but is also kind of sitting in the back on a tripod stand, and their respective families. We've all had different experiences with healthcare, but it's only brought us together. So fast forward to now, we've done a lot of advocacy. I talk about employer benefits, individual health, Medicare, Medicaid CHIP, short-term medical. We got credentialed in any way possible that we could to be able to be a support system to the Lancaster and surrounding community. We have clients in 11 different states at this point, so there are differences in different markets, but we try and keep on top of it. And what that's resulted in is a relationship with government groups, with trade groups, and there are times that we are asked to comment for Lancaster newspaper, the Writing Eagle, and most recently the Lancaster Physicians Magazine on price transparency. So we're going to talk about the past a little bit. We all know about Social Security. We're all hoping that it's still there when we retire. But in the original Social Security Administration documentation that came to light in 1935, there were provisions trying to offer a senior supplement to healthcare. They realized that in the 1900s, life expectancy was about 40. Now we're much higher than that. And we have to make sure that our seniors that aren't working and don't get employer coverage would have access to coverage. They dropped that. They dropped healthcare from that bill because they didn't want to throw any wrenches into getting Social Security in place. And that was one thing that was holding us back. 14 years later, Truman tried again. It was blocked. We saw in 1962, John F. Kennedy tried again. It was blocked. And in 1965, Lyndon B. Johnson finally got it approved, but it was under a very specific agreement. They had to go to the American Medical Association and say, we want this for seniors. And they said, we want to be able to charge whatever we want. So they defined the cost of healthcare as long as you're charging what's usual and customary in your area, that's acceptable. How do we define usual and customary? What everyone else wants to charge. And at that point in 1965, we were only at 5% of GDP for healthcare. We had a lot more intimacy with our providers. We knew what was going on. We didn't have to go to a million different networks. We didn't have to worry. And a lot of it comes down to the fact that if you look at the healthcare paradigm, it is patient, provider, payer. Those are the three edges of that triangle. And what most people don't realize is the customer is always the payer. Patients are the product in our healthcare system. If you look at a $500,000 bill, if you look at a $250,000 bill and you have a $5,000 deductible, that provider is relying on $245,000 coming from the insurance plan and $5,000 from you. So at the end of the day, the relationship is stacked to help that relationship, the provider and payer model as opposed to the patient model. And if you look at 2003, we had established Medicare Advantage. We had different plans that were set up. We realized that GDP, even at that point, was 17.4% was going to healthcare. Go ahead.
So the spending percent that you show there as part of the GDP, that includes both us and the insurance companies.
Right, that's the full outlay to the healthcare system. The healthcare system to the compared to GDP. So 2008, we had a recession, fun times. Not really, but we were trying to figure out different ways that we could stimulate the economy, and handing money back to the banks didn't seem like a very good opportunity at that time. It was very easy for legislators to say, one of the ways that we can throw money at the market is through healthcare. All of our records in 2008, only 8% of hospital systems actually used a digital record. And if we can throw money to build out this electronic health record, or EHR, then we're putting money where it needs to be. We're putting an infrastructure in place to help medical in the future. And we're making it to where they can work together and have less errors. CDC can find more causes to the pandemic, which we had SARS in 2009. There are a lot of opportunities where we can pull healthcare together by developing this platform and saving money. We're going to have less fraud, waste, and abuse if we have a digital platform. So they enacted the HITECH Act in 2010. We went from 8% of hospital systems using a digital record to 97% in 2017. Records are online, which is fantastic. $36 billion got thrown to the healthcare system, and we went to having, at this point, I think it's 700 EHR platforms, because it was free money to this industry. Go find a provider, get them online, you will get paid, we will reimburse the provider, and it's an easy conversation to have. So really that's what I'm trying to look at today is we're going to plug into how We're evolving with healthcare and our platform Snap Health, kind of the next phase of healthcare, but we're also going to, I promise, share other things outside of our system. We're not here to pitch anyone, but we do want to walk through why that hasn't really helped. We went from 2003, 17.4% of GDP going to healthcare, to 2019, 17.7% of GDP going to healthcare. So it's really, we want to look at how can we break this down and help patients. So I do have a video here that I'm going to have you guys watch. It's only 7 minutes, and I promise it's worth the time. But it's going to walk you through our healthcare system. We just finished at the Tech Accelerator, and I'll get to that in a minute, but this is a challenge that we have tried to figure out how to truncate and explain to individuals, because it is very, very, very complex, right? The whole healthcare system is very complex. So I know you've already seen this, and I will say that video is from 2019, so there is hope. And really, what we had come out of that experience is, you'll see here, the only green line that I've checked off is patients' records are digital, right? Like, that's what the argument is with healthcare in the 21st century, is we need to be able to handle medical claims efficiently. You know, United Healthcare, the largest health system, processes 2 million claims a day. There's no way they're reading all of them. There's no way that we know that everything is kosher and working properly. And there's no way to regulate currently fraud, waste, and abuse to the scale that we need it to, or to make sure that usual and customary is also fair, right? Now, we do have our own in-house hero, Erin. If you've met her on the other side, she works for Medicare. That's what she does, is tries to track down the bad guys. On our end, it's about empowering consumers to take advantage of what's out there. Our position with the Lancaster Physicians Magazine was all about hospital transparency. So since this problem was recognized in 2017, when we had mass adoption of these digital records, every request to make it more interoperable was met with HIPAA. Oh, we can't share our records, there's HIPAA. We can't do anything, there's HIPAA. So in 2016, there was regulations that stopped blocking from doctor to doctor, trying to make it easier and more transparent when we do referrals to a specialist from a primary care physician. 2019, we also had insurer blocking removed. And in 2022, the rest of the regulations are actually going to go into place that help in 2 ways. One, price transparency. So if you have a chance to look at that article that we wrote, it has a direct bit.ly to every hospital system in the area, LGH, Wellspin, UPMC, and Hershey. Their direct medical record that breaks down by procedure code what they charge by insurer. So you can actually see, if I have this specific medical code and I want to compare, why am I paying $500 when you're willing to accept $200 from a competitor insurer? You can start actually planning out healthcare. When it comes to prescription management, for years, CMS has gotten records, and Brent's actually helping us with this right now, from all of the carriers about what they charge for a prescription. That is based on 3 things: the manufacturer of the medication, the insurance company that you have, and the pharmacy you see. Those 3 variables make up a 50 million row data set of every medication, costs, what it costs to fill it at CVS versus Wise. And there's a lot of those pieces that are coming live and available. So I'm going to start with our company because I can control that. And then I'll walk you through outside resources that would also help you. Up until now, you know my story. I have a brick and mortar. I went to try and raise venture capital in 2018 regarding our platform. What we got from VC firms is you have a great idea, you offer a lot of disparate resources, and you're only scalable to a certain extent. You have to download your brain into the next person, and not only do you have to download your brain to the next person, you're only scalable as long as you can bring the next person, the next person, the next person, and we can't sell it, right? And that's what VC firms care about. So we had a conversation around making why if I'm downloading it to person, why can't I download it to a platform? Which is where Snap Health came from. We finished the Ben Franklin Accelerator during the spring. We were given 6 minutes to explain our whole pitch, and it's guaranteed that that is a very hard 6 minutes with 2 minutes of judges asking questions to show not only the problem but also profitability. And we've had nothing but a good relationship with them since. We did not win that accelerator. So again, if we go back to our healthcare system, this is what it has been. Every single part of the system has their own portal, has their own patient portal, has their own access point, whether it's your employer, your insurer, your provider, they have their own way that they've sliced this. So part of the being able to access your health records is they needed to deal with what that video said, where there are inconsistencies across the market. There's a protocol now that requires standardized information. And it gets down to some systems might have Social Security where it's 3 digits dash 2 digits dash 4 digits versus another one that's just 9 digits. And that can throw things off when we're working with interoperability and talking from platform to platform. So the goal, we and 2 other companies are talking about building systems that pull everything together. So I'm going to show you different systems that are out there, different tools that are out there that we are already using. They will eventually be integrated into our platform because they are API based, meaning that we can go request all the data on the back end and build it into one unique system. And then obviously from our perspective, we don't want to charge consumers. Our system is about helping consumers make better decisions, manage their healthcare, organize all their records, and actually see from doctor to doctor, regardless of who writes their paycheck, what the actual best doctor is out there. So this is all the data required to be readily available to you. And I think that's important. If you can pull in demographic information, if you can pull in all of your diagnosis, all of your notes, everything that you have, procedure codes, diagnostic codes, into a system immediately that feeds into that system regularly, it's in your pocket. You don't have to go and ask for medical records. The goal also is that your brokers don't have to go and ask you to refill out a new form every time you want to join an employer plan. Your provider shouldn't have to ask for a medical records request and wait for that before they can provide treatment. In our case, we had someone that it took us 5 months to get medical records to prove that they didn't have rheumatoid arthritis because they required 3 different times to prove that they weren't, that they were who they were with a HIPAA authorization, and they got a bill for $108 for those records. Moving forward, as long as you're using a third-party system, it is free. So aggregating and building out a platform for you is really the important part. This will help improve health, manage all of your team members, whether that's employers that you want to have access for claims and trying to negotiate a lower rate for you, your broker when they're actually trying to process your paperwork, and you don't want to fill out another form to try and get that done. You can see all of your medical treatments, diagnosis, upcoming appointments, scheduling, all of that in one place. Price transparency, and then triage. If you're in Myrtle Beach on vacation and you are incapacitated, you should be able to have an emergency contact that, so long as the hospital is listed in our system of, verified doctors, verified hospitals, and they attest they're incapacitated, that emergency contact can release your records. Immediately, you're not getting pseudo treatment and potentially medications you're allergic to because of your health care. So some of the examples, these are things that we use right now, right? I want to walk through pricing. This is medication pricing on Medicare.gov. This is by plan. So someone would say, I am looking for a plan for Medicare. I take, Rezatriptan, and I'm trying to figure out where pharmaceutically I should go get it filled, what pharmacy I should work with. And you'll see in the middle, CVS actually has their price at $196 versus all the other that are closer to $250 to $350 as far as medications are concerned. Those data sets are updated monthly. So you may get a notice that says CVS just raised the price on your medication. You should be able to get it at Wise for cheaper this coming month. The variables that don't change in that case are your plan and the medication, but you can always change from one pharmacy to another. Quality, if you actually look up hospital compare, all you have to do is look up hospital compare. You might want to know if your physician scores 1 out of 5 stars on sending a summary of care to referrals. Because if you're trying to coordinate care with multiple physicians and your physician is known not to really get the right data to the right people, the woman that was on that video, the doctor that was on that video said, when a specialist picks up your medical records, it's like getting a 200-page book. You're expected to write page 201, and you weren't given page 50 to 100. It's a problem. So those are other capabilities. This would be our dashboard, and I'm going to zoom in just on the bottom part where we're talking about tracking. I have a refill ready at CVS. I have an upcoming appointment for my son. I know that I have to worry about the dentist. I know that so far this year I'm at $867 out of my deductible. I'm pretty close to meeting that. I can go in and pay my bills. I can immediately see from a copay perspective that I could either go to urgent care for $75 or I can call a Teladoc for $50. So this is kind of where we're headed as far as healthcare. We've run into this thing where at the end of the day, providers and payers have been hiding behind HIPAA and hiding behind legislation. And Congress has said, we need transparency. We need people to be able to see what the actual price negotiations are, which will do two things. You'll be able to yell at them because you know that it's cheaper if you had a different insurer. And the insurers can better negotiate, why am I paying $100,000 for the same bill that Highmark's paying $50,000? So all of this leverage should start helping us drive down prices. And in addition to that, it should allow you to have a piece in your pocket of your health that you can manage proactively and reactively. What bill is coming in or trying to price a procedure. I'm not saying you have chest pain and you're trying to figure out where to get where to cover a heart attack the most efficiently. But in a general sense, we talk about someone who goes to their family doctors referred to get a sleep study, and we have a couple weeks to figure that out. We've been snoring for years. We can probably handle taking a quick look online, going into a central hub to see that the best doctor for that may not be LGH, even if I'm getting referred to LGH. And the best price for that may not be that best doctor. You get to weigh those variables, but that should all be in your control. So that's our platform. I did want to also provide some other pieces. Healthcare Blue Book is another one that you can actually price with the average cost for any given issue. Kind of like Kelly Blue Book, right? It's really designed to say that you're getting overcharged for a medical claim. And I know we've been conditioned, but every part of healthcare is negotiable. Just because they send you a bill doesn't mean you have to pay it. They've negotiated a lower payment with another insurer, they can negotiate with you. And at the end of the day, most people don't even realize that even outside of negotiating, if you're under 400% of the federal poverty limit, which In English, if you're a household of 4 and you make 105,000 or less, most of your hospitals have a financial assistance policy that will pay up to 100% of the medical bill. Because again, if we go back to that other scenario, if they're getting $245 from the insurer, they've already gotten $245,000. So they have, most of them are nonprofits where they have a budget, about 5% of their income, to be able to pay and help with financial assistance. Hospital Compare, again, that's where the 1 out of 5 stars or 5 out of 5 stars would come into play. You can actually go on Medicare's website. This is a tool that's free to use that you can verify physicians, you can verify hospitals based upon a bunch of different quality metrics. So if you're getting a referral to another doctor, it's always a good idea to look at that. The stars, it's not, it's not like ratemyphysician.com or whatever. Those stars are based upon quality metrics that actually put money in their pocket. Each year they report to MACRA and MIPS. They are internal systems that they have to report to CMS. And if they record higher ratings of quality in any of those categories, then they're actually paid more from Medicaid and Medicare. So they are working very hard to get those categories right, to get the numbers right. And it's not somebody who's going in and putting their own profile in and saying, this is the best doctor, you should see him. It's impartial data. And then the last part, we're working on this at the state level. We as in Pennsylvania, not we as in us. Pennsylvania actually started a contract with Findhelp.com, their parent company, or Findhelp.org, their parent company. I'm going to show you that website. It is something that anyone that's struggling should look at. Our contract at the state level is really to make it more Pennsylvania friendly. And if I could spell. So if I search 17603, I can get 1,889 programs available to me immediately, whether that's food delivery, if I have someone who in health, help paying for healthcare, discounted healthcare, health insurance, prescription assistance. So if I click on prescription assistance, it's going to show me every nonprofit in the area and how they support my family. And this is free. You don't have to put in your email to get all of this data. There are 1,800 programs by nonprofits. You need free legal support, family management, adoption assistance. This findhelp.org is an incredible resource that can help you negotiate or help support you on the end of social determinants of health, trying to actually make an impact for a lot of providers. We always talk about...
Is that just Pennsylvania?
No. So this is nationwide. Part of the reason that we had to negotiate with this company is that some of it, you have to be mindful. So look at it from your practice perspective, your expertise perspective, and see if you can find any misalignments. If I go to health and I look at help for paying for care and health insurance, right? That's my domain. I know that very well. I know that there's medical assistance for children and pregnant women, health insurance assistance and advocacy through this company, Kind Health. But I also know that healthcare.gov, which is listed here, is a federal program that, as of last year, was not available in Pennsylvania anymore. So it does take a little bit of research and due diligence to look into something like this. But again, that's harmless. If you go to healthcare.gov and you plug in your zip code, they're going to push you to Penny anyways. So it will route you to the right place. But it's going to show you what federal, state, and local programs are available and what nonprofits are available to support you. The video I had you guys watch was from the Kaiser Family Foundation, national nonprofit focused on healthcare. They have this article, Death by 1,000 Clicks. The video I had you watch was number 2 of 4, and they take it from multiple perspectives, from the physician's perspective and burnout and how they used to be able to handle 32 patients a day with only one assistant to now they're handling 20 patients a day with 4 assistants because of the burden of healthcare on them to try and provide support. But it's definitely a good resource for you. So yeah, so that's all I had. I wanted to thank you guys for coming out, and I'm here to answer any questions that you may have about healthcare. And if this wasn't necessarily an expectation you guys were walking into, but you had an off-ball question, I'm happy to answer any of this for you. Yes, Dana.
I have a question about the Snap Health. It's like basically an app, right?
It'll be a web app. Yep.
Yeah. So, and this hasn't been built yet.
It's partly because most the final regulations don't go into effect until January of 2022. Okay. So we can build out the algorithm, we can build out the databases, but we can't necessarily roll it out to the public because what we want, we can pull the doctor records at this point, but we can't pull what is actually billed to the insurer. So if you can imagine your record may have 80% of the information, but you see a boutique dermatologist that doesn't link into your practice, they're still going to bill the insurance company. So until we can make that 80% 100, we're not going to roll it out. We're not in a rush. We want to make sure it's right for people.
Yeah, that's really exciting. My question is, like, thinking from a mom perspective, I'm getting my kid into a new pediatrician. Mm-hmm. You're saying that they will accept my medical records from Snap Health rather than having to get it from the other doctor and transfer it?
So that's the eventual goal on our end. We have to take it in phases. There are security protocols that we have to meet in order to get it to each one. Our first goal is SOC 2, which is the protocol that the IRS uses and CPAs use. So it's a pretty darn robust security protocol. But in order to even walk into healthcare systems, they have their own box to check, high trust, that is a $200,000 walk-in. So that'll be phase 2 for us. But yeah, that'll be the end goal. In addition to that, we also want it to be able to be a dashboard for school systems so that when you have to verify vaccinations, it can be done immediately. You plug in the student's information and they would have it. We don't have enough time in the day, so. Why are you laughing, Paul? Is it not Paul? Steve. Why did I think you were Paul? I don't know.
Does this look like a Paul?
Yeah. You're not appalling, but you're.
Well, I appreciate that.
Yeah.
Personally.
Why were you laughing?
Why am I laughing?
I'll take the hard questions.
So, I just became a partner of a company that works in the healthcare space.
Yeah.
And part of what they do, part of what we do, is we vet and support, and in some cases sell technology that's very similar to what you're talking about.
Yeah.
And I've heard the same thing over and over and over again. And my questions continue to be, okay, what would be the one thing we could do across the nation to give you access to the data like today?
Yeah.
And everybody goes, deregulate it? I'm like, okay, cool. So why don't we just have people start signing documents that say, no, I waive my HIPAA rights. You can send my data to anybody that needs it.
Yeah.
Have a great time. Bye.
Yeah. So the challenge on our end, because to your point, we're with 2 other firms that I've been monitoring. One is One Record in New York. The other one is LifeOmic out in California. LifeOmic is the CEO is a 4-time startup entrepreneur, came out of retirement. His last sale was a $4 billion company. So his vantage point on this problem is more on the research side. It's nice to say I waive my HIPAA right. They're not even giving data to researchers to try and figure out, are there trends that result in issues? So he's looking at it from that perspective. On the a company up in New York, she's coming at it from a vantage point of, we had lupus. I don't remember if it was her or if it was her co-founder, but they had lupus, and there was no way that they could organize everything in one place. So regulate or deregulate, it's still important to be able to organize and make it actionable. On our end, we're looking at it a lot from a financial perspective, in the sense that if you could walk into the year and be able to see a system that says, here's the best place to get your medications, here's the best physicians that are going to support you in the area. And in addition to that, if we can offer you a tool that says, last year you went to the doctor 4 times and your medications are X, the best option this coming year, whether it's through an employer or through Penny or through whatever, is going to be this plan at this cost. You look at Penny right now, it wants you to scale, it wants you to say, I am healthy on a scale of 1 to 5, and then they put an estimated amount based on what you would actually spend out of pocket. So for us to be able to take your medical records and meaningfully say, you had 3 different specialist appointments, next year, Highmark, under this plan, it's going to be $50 to you all in for the year versus Capital Blue. Again, it makes a better consumer. And that's our end goal. But yeah, I agree with you completely. I think on our end, part of the advocacy side is recognizing how the system works, and then recognizing where it falls short, how do we pivot? So we're in DC a couple times a year, usually 4 times a year. Right now with COVID, we're not. Meeting in the Humphrey building down in Department of Health, trying to solve some of these issues. But it's interesting on that side.
Question for you. With SNAP, are you going to partner, is this just going to be for Pennsylvania, or is it going to be beyond that?
Yeah, so we have a timeline. I won't, it's
All
a lot of, but
PA Start.
so patients, PA Start, Mid-Atlantic, National, and then we're going to roll out to brokers, and then, because again, it comes down to the regulatory requirements and all of that, what their security protocols are, and where we can make sure that the business is sustainable to help more people, especially if we're charging $0 to consumers for it. So there are layers to it, but yeah.
And then for those of us who have to get our own insurance, we're not under, which I think is a percentage here. Obviously, Penny is where we as a state are going to for, like you, and then organizations like yours or Penny. Is SNAP going to integrate with like whatever the health program is for that state?
Yeah, so a couple things. So healthcare.gov, still available in 36 states, I think, at this point, which we can have direct integration under what's called an enhanced direct enrollment, which means we can take whatever data we have in our platform. We don't even have to ask you all the different questions. And we have a back-end algorithm that says, you have a 23-year-old, that person should actually be on their own plan with medical assistance. All of the stuff we do organically, right? When you look at a state like Pennsylvania or New Jersey or Nevada, California, Georgia's trying to work on it as well. They're under what's called a 1332 waiver, which basically means that they've gone to the government and said, we're relieving you of your responsibility. As long as we can do it state by state and it's less costly to the government, we keep the delta of whatever we saved you. Penny is that program here in Pennsylvania. At the same time, we have to recognize that the Affordable Care Act was designed by the Obama-Biden administration. So this is round 2 of that. This is part of the reason that earlier this year there was legislation to make more tax credits available to consumers, more access to coverage. They're even going back to Georgia and fighting with Georgia to say you need to reapply for your waiver to be able to offer in the state, because the original application was under the old administration, and we don't think that it actually fits within the framework of what we're trying to do. So 2 options could happen, is that we go back to healthcare.gov, which we have an easy inroad with, And the second option, which is more realistic, is that because there's a federal infrastructure that allows a third party like Health Sherpa or Get Insured or any of these other companies to be a separate entity, a public or a private entity, but be able to be a replacement of healthcare.gov, that does save money on the system, because then healthcare.gov is not fielding all the tech questions and all the issues that are involved. So they have pushed to make it to where even if you're a state, if we know this EDE platform is good at the federal level and you move to a state level, you need to be as efficient as we are, which would mean that we could link up to Penny. So that's still a couple years out, but it is something that we're eyeing as well. At this point, it's you fill out everything. We say Highmark is the best one, and then more than likely we're going to have a team behind the scenes that's transcribing that to Penny.
Gotcha.
So.
All right. Oh, excellent. Any questions? No? Thank you, Josh.
So
That's
great.
really good.
Thanks.
Changing the face of healthcare with Snap. Good job.
Thanks for checking out our YouTube channel. Be sure to subscribe to keep up with everything happening at the Candy Factory, a co-working and social club in Lancaster, Pennsylvania.